Mainstay of the treatment of Hallux valgus is usually operative treatment, because conservative treatment does helps to stop the progression of the disease, but is actually cannot revert the changes which has ever occurred. Now coming to the what type of osteotomy or procedures which needs to be done. There are broadly divided into two type of procedures. One is called as soft tissue procedures and other is the bony procedures. Now bony procedures include metatarsal osteotomy such as distal in the diaphysis or in the proximal metatarsal osteotomies as well. And soft tissue procedures include modified McBride procedure, which is usually done in the mild to moderate type of Hallux valgus. What is important to understand over here is that there is no actually consensus over the what is the cutoff for when you call Hallux valgus a mild Hallux valgus, when you call it a moderate Hallux valgus, and when you call it a severe Hallux valgus. There is generally consensus that intermetatarsal angle greater than 13 with Hallux valgus angle greater than 25 is usually considered a moderate Hallux valgus, and from Hallux valgus angle from 15 to 25 with intermetatarsal angle more than 9 to 13 usually is considered as mild. For both the cases, for mild to moderate Hallux valgus, the treatment is usually in first soft tissue procedure, that is modified McBride, along with the distal metatarsal osteotomy, which is usually called as chevron osteotomy. The chevron osteotomy is done. It's a V-shaped osteotomy done at the distal metatarsal angle, and to actually correct the pathoanatomy of the first metatarsal head as well as the first ray. As you know, that first ray has actually gone into plantar flexion and pronation. So this osteotomy is sort of it realigns the first metatarsal head into normal kinematics. But if it's then once we have done the osteotomy, we can apply a screw, which you've seen it over here, that once the osteotomy is done, the deformity has been corrected. A single screw is more than suffice. But sometimes what is important to understand is that it's not only in one plane. If you see it over here, it's laterally, it can be seen like this, and on anterior posterior view you can appreciate that actually the pronation of the first metatarsal head has been corrected as well, because the osteotomy is not done in single plane, it's done in multiple planes. And this not only corrects the plantar flexion of the first ray, but also corrects the pronation of the first metatarsal. But if it happens to be a severe deformity, that is, despite having a chevron osteotomy you cannot correct it, then we may have to go for a double metatarsal osteotomy, which may involve, along with the chevron osteotomy, you do a diphyseal osteotomy as well, which can be seen it over here. That you do the chevron osteotomy at distal metatarsal level and do a diphyseal osteotomy, which is done in the diphysis of the first metatarsal, called as the scarf osteotomy. And this can be sometimes done if it is moderate to severe type of Hallux valgus. What is moderate to severe? Which means usually Hallux valgus would be greater than 25 or maybe more than 40-45 degrees, and you have intermetatarsal angle may be greater than 15. So there is a moderate to severe form of Hallux valgus. You may have to go for either the diphyseal osteotomy or double osteotomy, which may be involving the chevron as well as the using scarf both as well. Now remember, there is no actual exact consensus of what type of osteotomy has to be done. There are more than hundreds of osteotomies which can be done, and there's a different of combinations which can be done as well. This all depends upon the clinical clinician who's doing it, the surgeon who's doing it, and his experience, and how he actually assesses the pathology. As if surgeon thinks that it's moderate, he may go with a single osteotomy at the diaphysis. But if the surgeon thinks it's more of a severe sort of Hallux valgus, then he may go for a double osteotomy. So there is no clear-cut definition or guidelines what to do, when to do, and what exactly to do. This mostly depends upon the surgeon's preferences as well as his experience dealing with the Hallux valgus. Then certain other osteotomies are also available. As I told you, we have to assess for the first tarsometatarsal joint hypermobility. Why that is important? Because usually first tarsometatarsal joint is hypermobile in the case of Hallux valgus. If that happens, then we may have to go for certain basal alignment osteotomy as well, or even the first tarsometatarsal orthodesis called as lapidus procedure, which can be seen it over here that they have actually fused the tarsometatarsal joint. Why? Because even if the osteotomy is done over here and corrects the kinematics, hypermobility will not be able to completely actually bring back the windlass mechanism. And why we need that windlass mechanism? Because the foot is required to do the push off during the gait mechanism. Therefore, if there will be hypermobility at the first tarsometatarsal joint, the gait and kinematics would still be disturbed, and whatever, even if we have corrected all the angles. Therefore, sometimes either the basal realignment or we have to go for this procedure called as lapidus procedure, that is the tarsometatarsal joint orthodesis. Then what if you see post-operatively, once we have done the osteotomy, the best thing is to go for a measurement of realignment angles as well. Sometimes you have to go per operatively as well. This is just one of the x-rays. If you calculate, probably Hallux Valgus angles would be somewhere around 15 to 20, and intermetatarsal angle would be somewhere around 13 to 15 as well, or maybe more than that. But now there is no clear-cut cutoff. For some surgeon, it will be maybe a mild disease. For some, it may be a moderate disease. And for some, they may go with soft tissue alone. And for others, they say, okay, it's a moderate disease. We can go for soft tissue procedures such as modified McBride along with the distal chevron osteotomy as well. And they may eventually achieve like this. Now, in this case, they have gone with you can see there was a lot of callus and bunion was formed. This has been removed. Therefore, this means soft tissue procedure has been done along with the distal chevron osteotomy, which has been fixed with a single screw, and they have achieved almost all the angles normally. Although if you see Hallux Valgus angle has become normal, although I doubt that intermetatarsal angle is normal as well. Now this is which is actually the problem area. There is no clear-cut guidelines and what to do and when to do when this angle becomes this, because the gait and kinematics, the weight of the person and how person walks actually also depends upon what forces are actually on what muscles and how much the forces actually transmitted through the joints. All these are clinical factors which come into play and which are very difficult to actually assess on the radiographs only. But broadly, we usually calculate the Hallux Valgus angle, intermetatarsal angle, distal metatarsal articular angle, and Hallux Valgus interphalangeus angle actually. And then we assess whether it's a mild, moderate, or severe disease. If it's mild to moderate disease, usually soft tissue procedures such as modified McBride along with the distal chevron metatarsal osteotomy is more than enough. But if it's moderate to severe disease, we may require either a scarf osteotomy, which is a which is diphyseal osteotomy, or we may require a double osteotomy, that is at the diaphysis as well as the distal metatarsal chevron osteotomy along with the modified McBride. Depending upon usually it's clinical assessment of the surgeon, how he sees the disease and what the type of procedure he wants to go for. But most of the time, what is important to understand is that end goal is not actually the correction of angles. End goal is the correction of the gait of the patient. The patient is able to walk normally with restoration of windlass mechanism, which is more important than the restoration of angles.